right, hello everyone. It looks like it's slowing a bit, so I'm going to kick us off by introducing the topic and the speakers for today. We are in session 3 of the 2025 Implementation Science Reading Course series, and we are very excited about today's topic. Every year, we try to use a continuous quality improvement approach where we closely review your qualitative feedback and we solicit qualitative feedback from the small group discussion leaders. And something that emerged last year was we noticed a lot of attendees in the small groups had questions about how to adapt their interventions for different contexts or populations. And this was not something we had as a specific topic last year. So by popular demand, we have added it to the curriculum and recruited 2 experts in this area of exciting study to lead us. We're also very excited that they were willing to speak with us today because they both represent key partners of our Center for Dissemination and Implementation Science. Miriam Rafferty is the Director of Implementation Science at the Shirley Ryan Ability Lab, and Andrea Graham is the new Chief of the Division of Implementation Science in Medical and Social Sciences, which was a division just started this year because of the spectacular growth in implementation science across Feinberg. So we are really appreciative to them for sharing their expertise with us and for creating this brand new topic as an addition for our course. And I will turn it off. I believe Dr. Rafferty is starting.
Thank you, Dr. Becker. Andrea and I are both really excited to be here to talk about the innovation. What is the thing you are doing? You would have seen our readings for this week, which the first 2 are really kind of key readings in the field of adaptations. And the 3 recommended readings were some of the examples that we'll be talking about today, so you can dive into them more deeply if you're interested, as well as a glossary of terms. So one of those taxonomy style frameworks, if you're interested in understanding the jargon behind adaptations a little bit better. I'll be kicking us off with talking about selecting an innovation and the frameworks for adaptation. And then Dr. Graham will be talking about adapting innovations using user-centered design and applying user-centered design to implementation science. So she'll be giving some of those examples. I'll then go back to that case that we're going to be reviewing throughout the course to show you how they did some adaptation as well. So the first topic is just, what is it that you're going to be implementing? And in implementation science, we call that the innovation. If you recall from last week's slides, Dennis shared that in implementation science, we are normally focusing on the delivery system in these green boxes, the delivery system or the implementation strategies that support the adoption and delivery of an innovation with fidelity. In this talk, primarily, we will be talking about the thing that you are implementing. And if you recall from last week, that thing is normally one of the 7 Ps: a pill, a practice, a program, a principle, a product, a policy, or a procedure. Sometimes you might think that this thing could be an evidence-based intervention. It could be a measure. And that's why we call it the innovation, because it used to be that we would say like, oh, it's an EBP or an EBI, but it really could be a lot of different things. If you recall from the implementation research logic model, we have 2 stripes. We have this top part, which is the implementation strategies and the implementation outcomes that you'll be thinking about. And the bottom is the innovation or the thing. So the effects of that thing are the effectiveness outcomes. So if you are trying to implement, in my world in rehabilitation, we might be trying to implement an exercise program, and the effects of that exercise program are to improve the physical health or potentially the mental health of a person with a disability or disorder. So that's what we'll be kind of focusing on today. As we've kind of heard about through this course, normally implementation science or implementation research is focusing on which of the implementation strategies is going to work best for a thing that you already know is effective. And in this talk today, I'm going to really highlight what here looks like a red, like dead end. It's not a dead end. We need to be using implementation science, the philosophy of implementation science, early in our research, even if you're still in an efficacy phase of your research. Here we would call it designing for implementation. So when are we going to select this innovation, and when are we going to adapt the innovation? As we were talking about frameworks last 2 weeks ago, EPIS is one of the more common process models. It also has determinant frameworks built into it. But if we think about the process that's elucidated in the EPIS model, it's exploration and preparation, and then implementation and sustainment. So when we think about when we're selecting that innovation, it's normally in that exploration phase. And then you would be adapting the innovation during the preparation phase. And just to highlight some of the overlap between the different models, I wanted to layer a couple of different process models on top of each other. As we talked about last session, you're going to pick the process model that works best for your study or that works best for your grant. It might be a 4-year grant, it might be a 5-year grant, it might be a 3-year grant. So you might have more space if you have a two-page research strategy or a 12-page research strategy. How many things can you really explain step by step? But you see here EPIS. You see here the query roadmap that comes out of the VA system, and they just lump all of the pre-implementation under one category of pre-implementation. And they similarly have an implementation and sustainment phase. And again, here, the selecting an innovation is going to happen in pre-implementation. One of the process models, though, that we use most commonly in rehabilitation is called the knowledge to action cycle. And I wanted to zoom in on this a little bit today because it actually, in the steps of the knowledge to action cycle, they do talk about selecting your knowledge. Here, you could replace that with selecting your innovation. In the knowledge to action cycle, the first step is actually reviewing the literature or doing discovery style research. So knowledge inquiry is discovery. What's the new thing that you're trying to support or find or learn about? Knowledge synthesis is creating clinical practice guidelines that are meta-analyses. What's that highest level of evidence? And if you have an innovation with a high level of evidence, you would create tools to make it easier for people to implement that in practice. You then might look in your health system and identify a problem or a no-do gap. And then based on the no-do gap and what you know in the literature to be best practice, you would identify, you would review the knowledge and select the knowledge that you're going to implement. Then you adapt that knowledge to your local context. Then you're going to assess the barriers and facilitators to the knowledge use. Why isn't it being done currently? And then the next step is to select and tailor your implementation intervention. So that's your implementation strategies. So when we talk about when in the system we're doing we're doing adaptations for your innovation, it's primarily going to be in a pre-implementation phase where you're going to select your innovation. You're going to select your innovation or one of those 7 Ps, and then you're going to tailor or adapt that innovation for your local setting. This could be examples of ways that you might tailor it. Could be if you're working with communities that have different levels of resources. For example, if you're in a community like Northwestern Medicine, right smack downtown, where there's lots of stores and lots of gyms, where most people have ample personal resources and finances to be able to support their own health decisions, versus if you're doing something down at University of Chicago where there aren't a lot of gyms or exercise programs, you're going to have to deliver your innovation differently in those settings. I do want to highlight, though, that some of these tailoring your innovations are going to happen during your implementation phase as well. So during your implementation phase, you might get started with an intervention that you think is going to work. And you might, through like a series of stakeholder input, you might realize that something is not working. It might be that there's a problem with the intervention itself, or there could be a problem with your implementation strategies. And the nice thing about implementation is that there's ways to track if you make a change mid-course. And it might be that you kind of do one cycle through the EPIS model initially, and then you do another cycle through after you change something, and you're going to track those things as you go. But when possible, if you can figure out what you're doing and how you should be tailoring it or adapting it before you start, that's going to make your study more rigorous and stronger. So then the question becomes, how do we do that? First, we have to identify the problem or thing that needs implementing. And here we go back to just like the principles of evidence-based practice or evidence-based innovations, which is the hierarchy of evidence. Are you selecting an intervention that was shown to be efficacious in one study with no control group? Or are you selecting something that has years and years and multiple randomized controlled trials that show that it is efficacious or effective in the real world? Has there already been a pragmatic randomized controlled trial on it? We have a lot more confidence in something that has a higher level of evidence than just one small study. I think one of the things we sometimes see is, especially early career researchers, you do something in your PhD with a little intervention that you developed, and then it's like you want to scale to implementation. And that's where we start getting really cautious. Like, has there been enough research on this innovation to scale? Sometimes yes, and sometimes no. When you are adapting an intervention, let's say you do have this really, one of the 7 Ps, you have a practice that's known to be efficacious. So I'll say like cancer screening, which is one of the really important evidence-based practices for cancer control and prevention. If you want to change the way the screening is done, for example, should screening be done by your primary care physician, or is it something that can happen in the community, like the mammogram trucks that go around where a primary care physician is not involved in referring to that service? If you're going to adapt that for your community, you want to document who, what, where, when, why, and how you're making the adaptation. So in that example, how you're making the adaptation is by bringing the testing to the community instead of relying on them to get the primary care physician. Who suggested you do that? Hopefully, maybe you were talking to stakeholders who live in the communities, and can give you feedback that would be a good way to reach people. When you made that, did you do that after you did the technology that, sorry, I just saw the chat. Yes, love the laser pointer too. So I sometimes forget to bring it off this screen. So like, when did you make that? Hopefully you're doing that in the beginning of the study. If you start a study where you're expecting everybody to come to the clinic and get their mammograms, and then it's just not working, I would say stop. Like, don't just like keep doing the study where you're going to reach 5% of your population. If something's not working, stop and reevaluate your implementation strategy to see if you can make it better. And the key thing that I keep coming back to is work with your clinical and community advisors. It's not something, even if you're a clinician and you think you have the best idea since sliced bread for your work plan, I can't tell you, just like in 20 years at Shirley Ryan Ability Lab, how often I've seen like one person say, I've got the new way to solve this problem. And then they leave the organization, and 5 years later, somebody comes back and says, I've got the best way to solve this problem. And had that first person worked more with their advisory team and the organization, whatever they developed would have had a higher likelihood of sustaining. Some more kind of thoughts on how do you know if it's the right fit, and then how to adapt it. Do your literature review, look at the effectiveness of your intervention, as well as if there's already research on implementation of that intervention in your type of context. So there's starting to be more and more case studies and examples of this, so be sure to look for those. When we're looking at the intervention, think about the core components of the intervention versus the adaptable components of the intervention. And I'll give some more examples of that through the examples here today. Use an advisory board, include all the interested parties. So if you are a clinician, include other clinicians, include different disciplines, include people with the lived experience, include their caregivers, whoever would be interested or relevant for that project. Use surveys, and we do have some validated surveys and implementation. We'll cover these more in the outcomes section of our talk, but they're really important pre-implementation too, because if clinicians don't think your intervention is acceptable before you get started, don't wait until the end of your study to find that out. You can use focus groups and interviews to gather pre-implementation data, and you can use user-centered design processes, iterative processes, to continue to improve your innovation. Some frameworks. There are a lot of these. I'm not going to talk about all of them. I just want you to show and kind of differentiate that some of these are for planning before you get started, and kind of step-by-step processes to help you think about the innovation that you've selected, whether it's a clinical practice guideline, which is the original ADAPTE ADAPT guideline. There are some that are specific to different contexts. So National Cancer Institute one that's called IADAPT, the ADAPT ITT, which is HIV specific adaptation framework, and DDBT, which Andrea will talk about more, that comes from user-centered design. And then there's tracking adaptations that change some of those, that would track if you're making adaptations mid-cycle. Just to put that into context, this is a picture of the frame, which is the framework for reporting adaptations and modifications, and an expanded version. So know that this is expanded, and I know that you can't read it, but it basically is covering the who, what, where, when, why, and how. So it starts in the top and says, when did the modification occur? Were the adaptations planned, or did something just change? Like your clinicians just changed and did something differently? Who participated in that decision to modify? What was the goal of that modification? What was modified, And at what level of the delivery? Is it changing at the clinician level? Is management, administration changing it? Is the patient changing something? And what is the nature? And it gives you kind of a taxonomy for labeling your adaptations. And I think we really need to do a good job in implementation to describe these things. And I think it'll help new researchers if they're trying to, if they're looking into well, how should I change this for my context? Even if it's a different innovation, if you're looking to adapt to working in a low resource community, go look at other articles that adapted some other intervention in low resource communities, and you might get some ideas of the adaptations that could work for you. So now I'm going to pass it off to Andrea, Dr. Graham, to talk about adapting innovation, specifically using user-centered design.
Hi, everyone. Good morning. Thank you for the opportunity to present today. Miriam and I worked on these slides together, and I am still learning so much even through this talk and just really loving this session. So thank you for the opportunity. And now I'm excited to talk about a topic that I truly love, which is around the role of user-centered design. So next slide. Thank you. And so thank you, Amy. The concept of designing for implementation is something that Miriam started to talk about early on, which is what we want to be thinking about is not just where we always want to be trying to think about where the thing will go or needs to go, and not just where it needs to be now. And I think one of the beauties of this lecture is really thinking about the combination of implementation science and intervention science and the impact of both. You might be adapting an innovation or a thing, and you might actually be building it to start. And if that's the area that you're in, really encourage you to also have that lens of, could this be implementable in the future? Because that should always be our goal, to create impact. And so these are methodologies that you can apply to both of those things. And that's what we'll be talking about through the one of the case examples as well. And so when I think about designing for implementation, what we think about is really starting simple, but also being mindful of scale. And it's one of the key principles of human-centered design or user-centered design is really thinking about what we call an MVP, a minimally viable product. We're going to come back to that term, where you want to put things out that are more simple and building from there as we learn. So what's it going to take to do now? But then what would we need to do to change if that innovation or thing is exponential? You're scaling it up significantly, or if it's applied elsewhere in other populations and scaled out. And the thing that's really important to embrace, that has been a real sea change of my own thinking in this process, is being really mindful of the fact that people, settings, technologies, and policies, and all kinds of other domains that could fit in here, they change over time. We have to iterate. And so what we want to do is embrace methodology that understands that, which is why implementation science has really leaned into this idea that we have to make adaptations. And so what's important then is tracking that process and really having good methodology through which to do that. Next slide. So what is UCD, or user-centered design? And so it's an approach to designing technologies and services. It's often been applied in technology, but it can certainly be broader. And there's been lots of publications written in that space as well. An approach to designing technologies and services that is grounded in information from the individuals who will be using or impacted by those items or things, and the context in which they will be implemented. You cannot separate the person from their context. That's sort of the crux of all that we're here in this reading course thinking about. And that's really one of the key principles of user-centered design. And it's related to this field of human-computer interaction, which is an interdisciplinary specialty that's really focused on understanding how people interact with technology, or how people interact with each other through the use of technology. But again, user-centered design can be broadly implemented beyond technology, and I promise that's the most boring of the slides with lots of text. But the reason I love to embrace user-centered design and why we incorporated it here, and implementation science is more and more uptaking this methodology, is because its real goal is solving problems with uptake and engagement. And that's one of the key issues we're constantly thinking about in implementation science, is how do we get people to do the things that we know work? And it really thinks about those uptake and engagement questions at every step of the implementation cascade, meaning from the moment a clinician, let's say, is thinking about a thing to implement, to offer, all the way to offering that tool, to then making the referral, to then having the person actually uptake into that service, all through that cascade, this methodology can be applied. And it's relevant to implementation science because to date, we've often seen that interventions are not then designed well for the users and contexts in which they'll be implemented. Hence, the point of this conversation is really around how do we think about adaptation, because otherwise what we've seen a lot of things happen is low uptake and engagement, so failed implementation. Next slide. And here I'm also very involved in CBIT, the Center for Behavioral Intervention Technologies, and this is a model colleagues and I had put out that we think about a lot in our center as applied to both the innovation itself as well as its implementation, is that essentially the point of this figure is to show that engagement matters, that you could have the best thing on the planet, and if no one uses it, it cannot achieve clinical outcomes. It just can't. And so engagement needs to be a core mechanism that we're targeting. And that's really what HCD or UCD is really about, is targeting factors like how much people find it to be useful, usable, satisfying, not just how many clicks something gets or how many times you refer, but really, is it something that you're referring in a way that makes your practice more meaningful or impactful? Next slide. So this is a wonderful paper that I would love to refer you to by Aaron Lyon and Corner and colleagues, the two of them, where they actually thought about the role of user-centered design for psychosocial intervention development and implementation more broadly. So as I mentioned, often design has been in the realm of technology, but it's really a broader construct than that. And they really outline ways in which this could be applied to psychosocial interventions, again, the thing more broadly. So what design does, it focuses on factors like how easy can you learn this item. So if you think about having a clinician uptake to wanting to refer to an intervention, is it something that they can learn well, easily? How often are they needing to refer back to the manual? That's going to make it more unlikely that they're going to implement it. Is it efficient? Is it memorable? Does it help reduce errors? Is it a satisfying experience? Does it have low cognitive load? And does it exploit natural constraints? Meaning, does it account for context? So you could have the best tool, but if you can't use it in that moment, it doesn't create impact. And the thing I always like to say when I talk about design, it is not simply just focusing on colors or visual, even though that word creates that kind of a thinking. It's not just about that, and it's not simply doing a focus group. Next slide. So this is one framework, as we mentioned, and it's in the readings around one approach to doing design methodology. I'll just share, there's lots of other frameworks. At its core, I really believe the fact that they're really getting at the same thing. In the beginning, your goal is to be doing discovery. You want to be learning from relevant constituents who would use or be impacted by the thing you're doing, garnering lots of information, and then you're going to design and build the thing. Notice that the arrows are going circular so that it's something where you're constantly iterating. And that's one of the key principles of design, is that you're constantly leaning into the fact of the need for change, and then you're testing it. And parts of this cycle could happen again. So you are going to put it out into the world. And we all know that the moment we put things out into the world, things like we learn a whole lot more. And so it's really about this cycle continuing. Next slide. Miriam, you're doing amazing. Sorry, it's that on you. All right. Oh, just one back. Put more simply, I gave a presentation a year and a half ago where I actually just turned this into a whole lot of verbs. And again, you could see this is really, it's a lot of verbs because we're really focusing on action. And so these are just some steps to think about, and you could see how it maps onto it's not to create a new framework by any means, but it's really at its core. This is what you're doing. You're asking questions. That's a lot of what we're doing in implementation science, asking questions of our partners, of our the people, anyone who might be impacted by this tool. So this is what we're thinking about. Ask and then try. So one of the big things is put things out into the world. That's one of my favorite things to say, is if you don't get started, you can't create change. We have to try. And one of the key implementation strategies is actually to do small tests of change. That's a concept that we often embrace in user-centered design. Try it with a few people, and then think about with design, function over form. And again, I mentioned this idea of colors, but I really mean here, what is it that you want a clinician, someone in the community, what is it that you want them to do? What's the easiest way to get them to that, so to speak? And start with a minimally viable product or an MVP, and then iterate and embrace doing this rapidly. And really think about these methods. These are powerful tools for solving problems quickly. And that's one of my favorite parts, is often in quote unquote the real world, things move fast. And this is a methodology that you can use to help move things forward. Next slide. And of course, what's incredibly important is then consistently being mindful of the role of designing for equity. And this is a wonderful paper to consider with several key points around similar messaging around the role of designing for equitable reach from the beginning. Is what you're creating, who are you going to leave out? And often with design, I think about the negatives a bit more. And that's what I often lean into. Like, I don't care. I love to know what people like about a thing, but what I really want to know is what they don't like, or what's going to create problems for them, or what's going to be challenging to implement. Making sure you're having those voices known is very important. Similarly, we just talked about designing interventions with equity in mind, making sure that the thing is equitable, developing strategies that can actually reduce inequities in care. That should always be our goal. Thinking about the science of adaptation, so really tracking the changes that you're making and how you're doing that for equity. And then similarly, making sure that your implementation outcomes are really focused on not just reach in general as an example, but are you reaching the people who really need this in an equitable way? Next slide. So I'm going to give you two examples. One is from the case study or it's not the case study of the course. One of the optional readings is a paper that came out of CBITS here, where our work is a lot focused on digital interventions. And we did 5 case examples to show the process of the human-centered design process through different interventions and implementations that we were working on. And I thought Kaylee Cruzan, shout out to her, her section was a really beautiful model of this, where she's partnering with Mental Health America to design and implement a digital intervention for non-suicidal self-injury, or NSSI. And so concurrently, and you could read in this case study, she was doing individual interviews with young adults to think about the thing itself. She created prototypes, meaning working versions of those tools, to show it to the young adults, and then worked with a software developer to build it. And at the same time, she was also doing interviews with Mental Health America leadership to understand their workflows, like where would this tool go and how. We often think about designing for workflows. That's one of the key things I think about with implementation science. Like, literally, when in the process of a visit with an individual, or when a person shows up to Mental Health America's website, when would they be made aware of this thing, this tool? And that's what this case study exemplifies, and the way in which she used design methodology to do that. And again, my point of showing that is what Miriam was showing in the very beginning of that subway map. It's both levels, right? Like, you have to be thinking about both its implementation and the thing at the same time. Next page. And then this is a trial that I'm leading, where we're implementing a digital mental health intervention in ambulatory care coordination. And the reason I mentioned this one is because what we are particularly focused on is that handoff from a clinician to a patient of the digital intervention. And long story short is, I truly believe that handoff is the most important action for reach. That conversation, there's so many steps in the implementation cascade where this can go awry, and that's what we're zooming in on. And so next slide. What I show you is 4 out of probably 35 Canva images that went through iteration, before we launched this trial. So we worked internally based on all of the qualitative learnings we had done early on to say, we need a handout to help people. That's an implementation strategy, a tool, like an educational material. We needed a handout to help people know how to refer. What was the best way to convey that in a way that's learnable, memorable, simple to digest, using those principles? And I show these are 4 examples where we went through so many iterations, and then we would show it actually to the care coordination team. They would give us feedback. We'd revise it. We would show it to other members of our team. And all that's to say, like, we did so much design iteration just for one handout, because of how important it was that this item it has great impact on our whole implementation process. And I think I have one more slide, which is to show there's a lot of ways in which user-centered design, I hope I was able to convey this, and implementation science converge. And this is one model, I always get the letters wrong. There's ways in which they converge. And at the same time, you'll find that other adaptation frameworks have some overlap and similarities. The goal is on the surface, there's some differences, but at the core, they're really similar in terms of embracing adaptation, but still being really mindful of tracking those outcomes. Thank you.
Thanks, Andrea. And now I'm going to bring it back to the case example that we'll be tracking throughout the course. So you might recall from last session that we're talking about screening and brief intervention for risky drinking in 10 pediatric trauma centers and 10 different health systems. And today, the things that I'm talking about are kind of on this this side of the circle, where how they selected the thing, and then how they might assess the barriers and facilitators to create the blueprint, which in this case, our example is using the implementation logic model. So how are they going to adapt this screening and brief intervention tool for each of the 10 different sites? And in fact, each of those 10 different sites might adapt it a little bit differently. They're going to think about the thing, that innovation, and they're going to think about what are the core components of that thing that are going to help drive the outcomes. Primary outcome they want to know is that the patients are following up with their primary care physician, and then also that there's reduced drinking. Now, reduced drinking is going to be a lot harder to measure, but we want to think about those core components that are going to help the patient follow up with their primary care physician. So the first thing to know, this is in the background of the article, which is that they had previously done some work that worked well. The screening increased from 11 to 73% of their eligible patients, with 90% of those who screened positive receiving an indicated brief intervention. So what they had started with worked, but it wasn't perfect. How could they increase those percentages? So they had gotten feedback during the initial study before the article that we're just talking about here. They gotten feedback from staff that there were two key barriers for sustained implementation. One was lack of integration into the electronic health record, and the other was lack of customized training for people with different roles. So how would nurses approach this problem versus a social worker or a physician or another leader? They all have different training needs, and they would be involved in the intervention in different ways. So the way that you would see this in the implementation research logic models, it actually does relate back to the barriers and facilitators assessments. And so now you might go through your process again and go back and look at barriers and facilitators to implementation. And ultimately, in the study that the case that we're talking about, there have been some new articles, a new one from 2024 that really described the core components of the program and then what they chose to adapt. So they decided the core components of the screening and brief intervention were that there was a validated screening measure that was done. So you had to use an evidence-based innovation. There needed to be concurrent biologic testing for, I'm assuming whether there were illicit drugs or alcohol in the patient. There needed to be a brief intervention delivered. So this isn't something that's 12 sessions of CBT. This is right there in the emergency department. And then to refer those who screened positive out. But some things that had to adapt at different sites were because there are workflow differences. Different emergency departments work differently. There are different roles, especially the supporting staff. So who delivered the components? Was it a social worker or a nurse that was coming in to deliver the brief intervention or to do the screening? And then the order that the elements were delivered in. Those were things that the team decided could be adapted across the sites. So I'm going to end there now to go out into our breakout sessions. But if anybody has any questions, feel free to drop them in the chat and let us know.
Thank you so much to Andrea and Miriam for that wonderful new addition to the curriculum. That was really exciting. And we're going to start, I believe, assigning people to breakout sessions, and also your sign-up group is listed in a spreadsheet in the chat. So if there's any issues assigning you, we'll also give you the option to kind of select your breakout room. And I think that will start momentarily. So thanks all. And I think we will convene again in 2 weeks, and we'll be talking about context.